Hello, good morning all. Welcome to the grand finale, day 7 of the CAMS Medmeet International UG Conference, an initiative by College Union 2020, Government College Kozhikode. This will be the first session of the final round of the medicine case presentation. We have an eminent panel of judges with us today. Dr. Jayesh Kumar, Professor, Department of General Medicine, Government Medical College, Calicut. We also have Dr. Danish, Assistant Professor, Department of General Medicine, Government Medical College, Calicut. Dr. Danish will be joining us in the next half of the session. I humbly welcome Dr. Jayesh to this event. Here are the general rules for the event. This session will be conducted in two halves, with different judges for each session. On both the halves, the participants will be given one short case each. The first case will be discussed with Dr. Jayesh in the first half of the session. In the second half, Dr. Danish will take the position of Dr. Jayesh, and then the second case will be discussed. All the participants will be given 30 minutes time prior for preparation. Each participant will then be given 15 minutes time for discussion of the case. A reminder will be given at 10 minutes. The participants are required to keep the camera and mic on while speaking. Please note that these rules will be strictly followed. We shall now start with the session. Sir, may I call in the first participant?
Yes.
Please note, this is test number 1. Test number 1, can you see my
Yes, I can see the presentation.
Okay, you can start. Sir, you may start.
Good morning, sir.
Good morning. Good morning.
So should I present the case?
But I can't see you. Huh? You present. Okay, present.
Okay, sir. Sir, a 38-year-old female came with the chief complaints of exertional palpitation since 3 years and progressive dyspnea on exertion since 1 year duration. Next slide, please.
Okay. Okay. Right. Proceed. Go ahead.
Next slide, please.
Can the slides be switched to?
So the next slide has a question.
Yes.
Your symptom analysis and approach.
Okay. So you had two symptoms, no? So
Yes, sir.
you have to analyze the symptom and fix where is the problem of this patient.
Yes, sir.
Okay.
So as she is having palpitation and dyspnea, we'll first
Yes.
like to rule out cardiovascular causes and respiratory causes.
Very good. Yes.
Sir, we can do that by the history. Palpitation points more towards the cardiovascular cause.
Okay.
Dyspnea, which is related to exertion, points towards cardiovascular cause more than
Okay.
respiratory cause.
Right. So if it is a cardiac, now is it a left side or right side problem?
So left heart
Left
problem.
heart. Okay. Suppose if it is right heart, what do you expect?
Sir, we expect there will be hepatomegaly, there can be ascites, there can be
Yeah.
generalized edema,
Yes.
raised GVP.
Yeah. Okay. Very good. Yes. Go ahead. Yes. So palpitation, your approach.
So palpitation, we'd like to find out what is the cause of palpitation here. Like, is it due to arrhythmia or due to
Yes.
any cardiomegaly?
Cardiomegaly. Can you get more specific?
Sir, left
Okay, one
ventricular
again,
hypertrophy.
arrhythmia you told, what correct? Arrhythmia related palpitation and mechanical causes for palpitation.
Yes, sir.
Hmm. Like,
So, so there can
which
be
are
other.
the,
So there can be
yeah,
other causes like
yeah.
hyperthyroidism.
That is, yeah, thyrotoxicose you can have, yeah.
Yes,
Then,
sir.
hmm.
Sir,
Cardiac, yeah. Yes,
left
come.
atrial enlargement, which can lead to
Left
atrial
knee.
fibrillation.
Okay, that is again arrhythmia related.
Yes, sir.
Suppose the patient is not having arrhythmia like atrial fibrillation or flutter or ectopic,
Yes, sir.
but they are complaining of palpitation. In sinus rhythm, when the patient is having sinus rhythm or tachycardia, still, I
Yes,
mean,
sir.
rhythm, not tachycardia, then what are the causes where you can
Sir,
get exceptional palpitation? Can you say a few other?
sir, in thin chest wall patients, in thin patients, they can feel palpitation.
No, when how will you approach? No, if a person is coming to the cardiac problem, you have
Yes, sir.
cardiac, then you have vascular. Then
Yes, sir.
suppose you see cardiac problem left side, then how will you approach? Your approach should be valve. Okay, then it can be myocardial disease. This can be a pericardial disease. This can be a coronary disease. This can be a shunt, or then it is vascular cause like systemic hypertension,
Yes, sir.
peripheral vascular disease, coarctation of aorta,
Yes, sir.
tachyarthritis, atherosclerotic involvement of aorta, radiation arthritis. They are all vascular part. Okay,
Yes, sir.
vascular part you will diagnose by palpation, auscultation for Droi, everything. And cardiac portion you have inspection, palpation, percussion, auscultation. This
Auscultation.
is how you approach cardiac.
Yes, sir.
Vascular, palpation, and Doppler, and your auscultation technique. Isn't it? So these are the two set of approach, vascular side and cardiac. My question is, when you have cardiac, no, you have to think already valve, shunt,
Valvular effusions.
cardium, pericardium, coronaries.
Yes, sir.
These are the acquired heart disease, isn't it? Okay. So now my question is, which are the heart disease where you can get exertional palpitation as a presentation? That's why valve and shunt and myocardial disease, coronary. Same.
Sir, we can get in valvular heart diseases like
Like,
mitral stenosis, causing left atrial
okay,
enlargement, or regurgitation lesions like mitral
yes,
regurgitation
very good.
or aortic regurgitation.
Aortic regurgitation, very good. Any shunt lesion?
Sir, uh, sir, in VSDs there can be palpitations.
Okay,
If
any much more common, any other shunt lesion that you know palpitation will be present if you are at the age of 40?
sir,
Hmm.
ASDs, atrial septal
Actual
defects.
septal defect, that's it. Okay, right. Right, correct.
Yes, sir.
Okay, go ahead.
Sir, in cardiomyopathies, there can be palpitations. Like dilated cardiomyopathy can present as
Yeah,
palpitations.
yeah. Why do they get palpitation? What is the mechanism?
So there is a left ventricular systolic dysfunction. So to
Hmm.
compensate, the heart beats more powerfully, and there is
Hmm.
palpitation.
You mean the cardiac output declines, stroke volume increases, isn't it? Heart
Yes,
rate?
sir. So
Okay.
Frank-Starling's law. So,
Yeah. Okay,
yes,
right. Okay, right. Can you say some endocrine cause for dilated cardiomyopathy?
sir. There can be thyroid-related like hypothyroidism.
Hmm.
Um,
Hyper. You mean
hyperthyroid.
thyroid? Yeah.
Yes, sir.
Hmm.
Um,
Then,
Sir, sometimes there can be postpartum cardiomyopathy, which can be
okay.
dilated cardiomyopathy, endocrine cause.
That's the situation now. My question is endocrine causes for palpitation.
Yes, sir.
Thyrotoxic is correct.
Uh, so the
Acromegaly,
acromegaly,
Cushing
yes, sir.
syndrome.
Yes, sir.
Okay, right. Pheochromocytoma.
Yes, sir. Episodic palpitations can be seen.
Okay, DCM.
Yes,
Dilated. Okay, right. So now coming back to your case, now you
yes,
link exertional dyspnea and exertional palpitation and say possibilities.
sir. The here exertional dyspnea and palpitation points towards
Mm,
cardiovascular causes. There
mm,
can be valvular heart diseases, which
mm,
can lead to left atrial enlargement and left-sided heart failure. causing pulmonary
Okay.
edema, and these
Hmm.
features. So mitral stenosis can be one.
Okay.
Mitral
Then.
regurgitation can be another. Mitral
Yes.
valve prolapse.
Okay.
And
Then.
so,
Hmm. Hmm.
so
And
there can
aortic valve disease.
so aortic regurgitation can
Hmm.
be the reason, but
Okay. Any congenital heart disease?
sir, in tetralogy of
Already.
Fallot,
No, that is a different presentation. No, but here.
yes, sir.
Hmm.
So
Congenital heart disease, atrial septal defect. You already answered.
ASDs,
Okay.
yes, sir.
Yeah. Then you go ahead.
Sir,
Go
other
ahead.
causes.
Hmm.
Uh,
Okay. All right. Now you again presentation. You continue. Next slide. Hello.
yes, sir.
Hmm.
So on examination, the pulse
Ah,
rate is 102 beats per minute, which is
yeah.
irregularly irregular, and the
Yeah.
blood pressure is 130 by 80 millimeters of mercury.
Okay.
So the JVP is not elevated.
Hmm.
On inspection, we can see precordial bulge is present.
Hmm.
The apex beat is on the fifth left intercostal space, 1
Hmm.
centimeter medial to the mid clavicular line, and it
Hmm.
is diffuse.
Hmm.
There is presence of left parasternal heave. Prominent pulsation can be felt.
Pulsation. Left directional pulsation.
Yes, sir.
Because you are now presenting inspection findings.
Yes, sir.
He. Okay. Okay. That's a left parasternal pulsation. Okay. Hmm. Then.
Sir, on palpation, left parasternal heave is present.
No, inspection wise, what do you think? Inspection.
So
After general examination, what information you got?
so that the JVP is not elevated, precordial bulge is seen, and
General examination, what is a striking finding?
so the pulse rate is tachycardia and irregularly irregular rhythm.
That means what do you think now?
Sir, atrial fibrillation.
Atrial fibrillation. Okay. What are the cause for other totally irregular pulse? It's a very simple question.
Sir, regularly irregular and irregularly irregular pulse. So one
Yes.
can
Yeah.
be atrial
Hmm.
fibrillation. There can
Yeah.
be ventricular premature contractions or ectopic beats.
You mean true frequent ectopics? Okay.
Yes,
What
sir.
about atrial flutter with varying block?
Sir, in atrial flutter, uh, sir, it will be variable.
Yeah. So these are the three important causes for totally irregular or irregularly irregular pulse. So here, what do you think? Most common is atrial
Atrial fibrillation.
fibrillation. Okay.
Yes.
Right. So can you say a few causes for atrial fibrillation?
Sir, there can be
Cardiac cause. Cardiac cause.
so stenotic lesions like mitral stenosis.
Now, whenever a question is asked in the cardiovascular cardiac system,
Yes,
you
sir.
have to think valve, shunt, myocardium,
And
pericardium, coronary, and blood affecting blood vascular. That is aorta and its branches. Right
yes,
now,
sir.
you answer.
So
Hmm.
in valves, you can have mitral
Yes.
stenosis, mitral regurgitation,
Right.
aortic
Okay.
regurgitation.
Hmm.
So,
Valve, then shunt.
so in shunts, we can have ASDs.
Hmm.
Uh,
Myocardial disease.
so atrial fibrillation can be present in dilated cardiomyopathy and restricted cardiomyopathy.
Then any other cardiomyopathy, will you get in hypertrophic obstructive cardiomyopathy, atrial fibrillation? When they develop atrial fibrillation, they deteriorate fast.
Yes, sir.
Yeah, hypertrophic cardiomyopathy, isn't it?
Yes,
Then
sir.
congestive pericarditis, will you get atrial fibrillation?
Sir, if there is
Sorry,
a
12 minutes are over.
Okay, okay, right, right. Go ahead with your presentation. So palpation. Okay. Now I can hear you. Okay, come. What is the incidence of? Hello.
hello, sir.
What is the incidence of atrial fibrillation in congestive pericarditis?
Sir, sir, it can happen when there is not enough room for the ventricles to
No,
dilate.
no, no, no. Around 30% of the
Okay,
patients
sir.
can have atrial fibrillation, isn't it? Right.
Okay, sir.
So again, coronary artery disease, will you get atrial fibrillation?
Sir, we can get if
Yeah,
the branches supplying the atria are affected.
yeah. Hello?
Yes, sir.
Oh, okay. Go ahead. Palpation?
So in palpation, there is
Hmm.
left parasternal heave is present. There is
Hmm.
prominent pulsation felt in the left second intercostal space close to the
Hmm.
sternum,
Hmm.
and second heart sound S2 P2
Hmm.
component is palpable.
Hmm. Okay, that's it. Okay. So
Yes, sir.
what is your diagnosis now?
Sir,
Possibility. Hmm.
sir on pal-
Infection and
sir on inspection, the apex beat is
okay. No, okay. In the apex beatis.
sir, it is almost on the normal range,
Hmm.
like fifth
Hmm.
intercostal space, and just medial to the midclavicular line.
Okay. So what is the striking finding you got?
So left parasternal pulsations and left parasternal heave.
Okay, that indicates what?
Sir, right ventricular hypertrophy or left atrial
Right
enlargement.
ventricular hypertrophy. What is the common cause of right ventricular hypertrophy characterized by pulmonary P2 and RVH?
Sir, pulmonary hypertension.
Okay, when a person is having pulmonary hypertension, how will you approach? How will you think?
So we have to first rule out it is due to cardiac cause or it is due to primary pulmonary hypertension.
Okay, so you will think, is there any cause on left side,
Yes,
right
sir.
side,
Right
or
side.
is there any shunt in between? Isn't it?
Yes, sir. Yes, sir.
Okay. Is there anything on the left side like MS, MR, AS, AR?
Sir, MS and MR can present with pulmonary.
No, any evidence in this patient? Are you getting any chance for AR or MR?
Sir, for MS, I can think because there is presence of atrial fibrillation because of the pulse
Yeah.
irregularly irregular.
Well, what palpatory finding you will get in the apex in MS? What is the nature of apex?
Sir, there will be tapping apex in MS.
So is there present here? Is it present?
Sir, there is no mention of
Not mentioned.
palpation.
In,
No, sir.
in MR, what apex you will get?
Sir, in MR, we'll give
Forceful.
thrusting apex, sir.
You mean forceful apex.
Yes,
Okay.
sir.
In AR, what finding you get?
Sir, in
What will happen to pulse?
sir,
Here
pulse
also
is
there is
what?
an atrial fibrillation. Yeah, you get now blood pressure change and peripheral signs of aortic regurgitation, cardiomegaly, anything present here?
So there are no signs of narrow pulse pressure as seen in aortic regurgitation. There is no
Yeah.
water hammer pulse
Is
mentioned.
there anything suspect BCM or hypertrophic cardiomyopathy here?
Uh, no, sir, because it is chronic history. So
Yeah.
and dyspnea is also present. So hypertrophic obstructive
So,
cardiomyopathy is less likely.
okay. So you think the pulmonary hypertension is not due to a valve or a myocardium or a pericardium or coronary or hypertensive heart disease on the left side, isn't it? Huh?
Sir, I think it is due to valvular heart disease, like mitral stenosis.
Mitral stenosis, okay.
Yes, sir.
Possible. Any other possibility?
Sir, uh,
Any shunt?
sir, ASDs can present with.
ASD is 10%. Very good. Atrial septal defect, isn't it? Whereas in
Yes, sir.
VSD, you'll get biventricular enlargement.
Yes, sir.
And
Biventricular hypertrophy.
again, if it is PD, again, you can get a left-sided enlargement, a continuous thrill. Nothing is described, isn't
Yes, sir.
it? Thrill is
Yes, sir.
not described. Okay. VSD also, you get left upper sternum thrill. That's
Yes,
also
sir.
not described. So the
Sir,
atrial septal
most
defect,
likely.
mitral stenosis
Yes, sir.
versus atrial septal defect. Suppose there is no ASD,
Yes,
no
sir.
EMR, what other possibility you will think? Anything
Sir,
on the right side?
sir, pulmonary regurgitation.
No, that is secondary to pulmonary hypertension now, isn't it?
Yes, sir.
Have you heard entity called primary pulmonary hypertension? Have you heard?
Yes, sir.
Huh?
Yes, sir.
Very good. What is that?
So there is a propensity of the pulmonary vasculature to be more concentric and more thick, uh,
Hmm.
leading to pulmonary vascular constriction, and that is
Yes,
causing pulmonary hypertension.
that is primary pulmonary hypertension. A condition that can closely mimic primary pulmonary hypertension is what?
So, Oh,
Have you heard pulmonary embolism? Two types: acute and chronic.
yes, sir. Yes, sir. The
Which
chronic one
condition?
can present.
Chronic.
Chronic pulmonary embolism can
Chronic
present.
thromboembolic pulmonary hypertension. Isn't
Yes,
it?
sir.
Okay, that can. Okay, right. So in atrial septal defects, and what for? So what is your question? ASD findings, auscultatory findings of atrial septal defect. Term.
Sir, there will be wide and fixed second heart sound.
Very good. Yes.
Uh, Sir, first heart sound will be normal,
Mm.
and so there will be presence of a murmur.
What murmur you will get in atrial septal defect?
Um,
Which what all murmur you will get?
so we can get a
Hmm.
systolic murmur.
In the pulmonary area due to
So due to the flow of due to left to right shunt.
left to right shunt. Okay, high volume
Yes,
passing
sir.
by normal. Okay, right. Then
Sir,
other murmur you will get in ASD. Will you get any shunt murmur? Yes or no? Due to that,
sir, I
in
can't hear you.
because in ASD there is a left to right shunt in atrium. No,
Yes, sir.
whether that shunt will
Yes, sir.
produce any murmur? Yes or no?
Sir, it depends on the size of the defect in the atrial wall.
No, that shunting across the atrium will it produce any murmur? That's my question.
No, sir, because the pressure gradient is not that
Yeah,
much.
that's it. Okay, correct, good. Then what is the first murmur you get? Will you get any murmur in the tricuspid valve?
Sir, we can get tricuspid regurgitation
Tricuspid
if
regurgitation or mid-diastolic murmur in the across the tricuspid valve. What will you get?
sir mid diastolic murmur will get.
What is the reason?
Sir, because of the increased blood flow from the right atrium to the right ventricle
Very good. That's
during
it.
filling of the filling
Okay, when
phase.
will you get tricuspid regurgitation related murmur in ASD?
Sir, when
Hmm?
sir when there will be shunt reversal,
Yeah, when the person develops severe pulmonary
heights and
arterial
fingers.
hypertension, functional TR. What is
Yes, sir.
ostium primum ASD?
Sir, it is the first defect present in the atrial wall due to the failure of closure of septum primum.
Yeah, what is the finding you'll get? How will you clinically diagnose?
Sir,
What are the other association of ostium primum ASD? Endocardial cushion defect. What will happen to
yes,
mitral
sir.
valve? What will happen to
Sir,
interventricular septum? What will happen to tricuspid valve?
so the mitral valve and tricuspid valves, due to endocardial cushion defect, they will show regurgitation lesions.
Yeah, that's it. So associated MR or
MR and
TR
TR.
or associated VST will tell you that is ostium
Yes,
primum,
sir.
isn't it? Right,
Yes, sir.
very good. Yeah, right, right. In which college you are studying?
Sir, my undergraduation is from Srimati Kashibai Navle Medical College, Pune.
Very good, very good. Good, right. Then, hello.
Yes, sir.
Okay, okay. That is ASD related finding. Okay. In
Yes, sir.
chronic pulmonary thromboembolic pulmonary hypertension, what finding?
Sir, mm, sir, palpable P2 can be present due to
Yes.
pulmonary
Then,
hypertension.
yeah.
So there can be left parasternal heave, epigastric pulsations, visible
Right, right. Okay,
pulsations
okay, okay.
pulmonarily.
How will you manage atrial fibrillation?
So we have to control the rate and the rhythm.
Yeah.
So and also we have to give anticoagulants to decrease the
What?
chances of thromboembolism.
Okay.
Sir, so for rate and rhythm, we like to give calcium channel blockers, beta
Yeah,
blockers,
right and
digoxin.
rhythm.
Yes, sir.
Right control is the rhythm control. How will you control rhythm? That is,
So,
you are converting atrial fibrillation back to sinus
sinus
rhythm.
rhythm. Yes, sir.
Chemically or electrically? Chemically, which are the drugs?
Sir, amiodarone can be given, digoxin can be
Yes.
given.
Digoxin.
Uh, yes, sir. So for rate control.
My question is rhythm. Atrial fibrillation back to sinus. Which are the drugs? Amiodarone you said.
Sir,
Yeah.
amiodarone, sir, adenosine
Yeah.
can be used.
Adenosine. Any other
Yes.
drugs? There are more drugs,
Sir,
no?
ebutilide can be used.
Then.
So we can use
Okay, no problem. Rate control.
so beta blockers or calcium channel blockers can be used.
Which calcium channel blocker? Will you give nifedipine like?
Sir, we'd like to give verapamil.
Hello?
Yes, sir.
Okay, right, come. That's about, okay, right. Atrial fibrillation, rate control, rhythm control, all you told. Okay, right. And discussion is good. All right. Okay.
Yes, sir.
Good. Okay. Hello?
Yes, sir.
Right. So any questions left in that all answered now?
Sir, auscultatory findings were asked
Yeah.
and
And what is the
symptom.
final? Okay.
Sir, yes, sir.
So finally, what do you think? This person, because you are not auscultation part, you are not. We have not given you the data.
Yes, sir.
Okay, but you answered it almost good. Okay, no problem. All right.
Okay, sir.
Next case. Hello.
Yes, sir.
Your next case. One case. Okay. Right.
So, sir, have you finished with this session?
Finished.
Okay, thank you, test number 1.
Thank you, sir.
Welcome.
Yes, thank you.
So please note that was test number 1. Sir,
Yeah.
shall I call it test number 2?
Oh, call.
Test number 2.
Hello.
Can you please on your audio?
Hello. Am I audible? Hello.
Yes,
You're
you are
audible.
audible. I hope you're ready with your presentation.
Hello.
Hello.
Hello. Am I audible?
Yeah, audible.
Yeah. Good.
I hope you're ready with your presentation.
Yes.
You will be given a total of 25 minutes for your discussion. I'll be giving time notification every 10 minutes. The stage is all yours.
How much time?
25 minutes.
Okay. Fine. So we won't be having the second session
You will be having the second session soon.
as well, right?
Sorry?
We will be having the second session, 1B as well, right?
Yes, you will be having the second session.
Okay. Fine.
Are you ready?
Yeah.
All the best.
Yeah.
Sir, you
Thank
may
you.
take over.
Good morning, judges.
Yeah, good morning. Present.
Yes. I have been given a history of a smoker who is a 70 years old male who has presented with chief complaints of progressive dyspnea on exertion since 6 months, loss of weight since 3 months, dry cough, and recurrent episodes of hemoptysis since 1 month duration. And currently, he presents with chest pain and increase in dyspnea. Examination findings which have been given to me are there is there is a
No,
palpable right.
again,
Yes, sir.
1 second.
Hello.
Hello.
Hello. Yes, sir.
Let me. So after hearing that history, so we'll go
Yes, sir.
analysis of history, then
Yes, sir.
analysis of general examination finding and its correlation with the history, and
Yes, sir.
then we will go to the system proper and investigations. Okay.
Okay.
Am I audible? Okay, right. So now your
Sir, there
duty
is
is
some
to analyze
echo.
the history.
There is some voice echo. Can the organizers please sort this audio problem?
Now, okay, now can you hear?
Yes, sir. Now it is better
Okay, now
audible.
you analyze the history, available symptom analysis
Okay,
and
sir.
system localization, with possible, I mean, anatomical plus pathological approach. And you, isn't it? So what are the symptoms?
He has been having progressive dyspnea on exertion since past 6 months.
Six
Along with
months
that,
history of
yes,
dyspnea. How will you approach
yes,
system?
it can be a respiratory system cause, or it can be a cardiovascular system cause, or based on the first
Cardiac
phase.
cause. Okay, right.
Yes,
Or any other condition where you can get dyspnea?
it can be because of hematological, maybe because of chronic
Okay,
anemia.
anemia related symptom, right. Okay, right.
Yes.
Then any other
Uh, for,
any other cause? Suppose there is no left heart, no respiratory, no
endo-
hematological anemia. Yeah.
endocrine involvement.
Yes. Then
There can be some trauma,
trauma
but
produce
less.
no pneumothorax, contusion lung, etc., etc. Then yes. Okay, right. So dyspnea, second symptom. So here, what is the difference between cardiac dyspnea and respiratory dyspnea?
Uh, Generally,
Hmm.
in case of a cardiac dyspnea, we generally get
Hmm.
dyspnea which is followed by cough, whereas in respiratory dyspnea we generally get cough which is followed by dyspnea. Uh,
Hmm.
oth- oth- Other than that, the dyspnea in case of cardiac case
Hmm.
worsens as the day progresses,
Hmm.
and along with that,
Now,
we will get.
in the mechanism of production of dyspnea, what is the difference between heart and lung?
The because of,
Respiratory.
in case of heart, it will be because of the back pressure mechanism which will occur, where
That
uh,
means in cardiac dyspnea, it is always due to fluid, either in the
yes,
interstitium or in the alveoli. That is
yes,
pulmonary edema related, isn't it? Main
yes,
mechanism. Whereas in respiratory dyspnea,
it can be also because of ventilation pathology.
it depends. No, each condition that is producing
Yeah, it can be.
dyspnea, the predominant mechanism varies, like asthma, airway, COPD, airway plus parenchyma,
It can be airway. It
fibrosis,
can be
replacement.
interstitium. Yes.
Okay, yeah. So the each condition varies
Hello, there
in
is
the
some
mechanism of
audio
genesis
problem.
of
Hello. Yes.
audio problem from some problem.
Test number one, can you please
The
mute
voice
your
is
system,
cutting.
sir is asking? Maybe
This
that
is
is
test
Hello.
number two. No, your number is two.
test number two. I'm really sorry. Test number two.
Oh,
Yes.
yeah.
Can you please mute yourself when sir is asking questions? Maybe that would be the cause of echo. Sir, can you please ask now?
Okay, okay, right, right. Go ahead with the present. So that is the first symptom is dyspnea, and second, what is second symptom? Hello.
So second symptom is loss of weight, which is present since 3 months.
Okay, any person coming with loss of weight, say for a few causes, or you can get significant loss of
Uh,
weight.
a significant loss of weight can be because of some underlying any underlying malignancy. It can be because of some any
Okay,
chronic
like
inflammatory condition in that particular patient. It can be
yeah,
because of nutritional deficiencies.
yes, GIT disorder. Okay, you told. Okay, okay, chronic malabsorption
Yes,
syndromes. Yeah, then
yes,
chronic infection like TB, malignancies. Then
yes.
other cause
And any sort of chronic inflammation, even involving thyroid gland, also can cause loss of weight, significant loss
thyrotoxicosis,
of
of
weight.
course. Then which infection? One is TB. Any other infection where you can get significant loss of weight? Hello.
HIV.
Yeah. Then right. What is anorexia nervosa?
Hello,
Hello. Ah, in anorexia nervosa, will you get a
hello,
loss of weight? Hello. Can I? Am I audible? Hello.
hello.
Hello. Hello. Am I
Hello.
audible?
Hello. Yes, sir.
Ah,
Yes, sir.
okay, okay, okay. In psychiatric problem, will you get loss of weight?
Yes, yes, sir. We can get like in anorexia nervosa. Hello.
Right. So now he's having dyspnea, loss of weight. Say a few conditions where you can dyspnea, breathlessness, and loss of weight.
Sorry for
Uh,
interrupting. Can you start over?
Hello.
uh, Hello. Yes, sir. Sir, would you please repeat the
Ah,
question? Hello.
the question is, if a person is having breathlessness and loss of weight, some lung condition where you respiratory cause where you can get dyspnea, some endocrine cause where you can get dyspnea, breathlessness, and loss of weight.
In respiratory conditions, we can get most likely in case of malignancies,
Yes.
where there can be dyspnea along with loss of weight.
Yeah.
Even in case of pneumonia or consolidation because of decrease in the appetite of the patient, we can get same. In
Which
endocrine causes,
pneumonia? You mean tuberculosis? Endocrine?
endocrine causes because of the specifically because of the thyroid abnormalities, we can get a progressive dyspnea and along with loss of weight, as in hypothyroidism.
Hypo or thyrotoxicosis?
Yes, sir.
Which one?
Hyper thyrotoxicosis, hyper.
Okay, very good. Right, right. Then what is the third symptom for this person had is having?
Yes. So would you please repeat the question?
You said dyspnea, then you said loss of weight. What is the third symptom?
Dry cough along with recurrent episodes of hemoptysis since past 1 month
Hemoptysis.
duration.
Okay.
Yes, sir.
So what is the definition of how will you define hemoptysis?
Hemoptysis is defined as association of blood in the sputum.
Then what is spitting blood?
Hello.
Hello.
Yes,
What
sir.
is
Would you
the
please?
actual definition of hemoptysis?
Uh,
Hemoptysis.
sir, I don't know the exact definition, sir.
You don't know
The exact definition.
of hemoptysis.
Yes, sir. Presence of blood in the sputum.
Okay, okay. Coughing out blood. Okay, right. Then what is spitting blood?
Hello. Yes, sir.
What is spitting of blood? Spitting blood and
Uh,
hemoptysis. What is the difference?
Spitting of the blood can be because of the hematemesis, or it can be because of an oral lesion. So
Hematemesis
that
and spitting blood are they same or different?
different, sir.
So my question is, what is spitting? Suppose a person is having some oral cavity problem,
Yes, he will
like
have spitting.
periodontitis or a malignancy or a telangiectasia bleeding in the mouth. What will it
Yes,
produce?
sir.
Is it hemoptysis or spitting?
Spitting cough, sir.
So that is effortless or effortful?
It is effortless.
Yeah, effortless. Hemoptysis?
It requires effort. It is effortful and associated with cough.
Yeah, cough. Right, right. Okay, right. Say few respiratory causes for hemoptysis.
Hemoptysis among the respiratory causes, it can be because of tuberculosis. It can be because of a carcinoma.
Yeah.
It can be because of arteriovenous
Mm,
malformation.
Okay, then any other? Now, okay, right.
Yes,
Yeah.
sir.
Cardiac cause for hemoptysis.
Cardiac causes for hemoptysis may be because of pulmonary stenosis causing black pressure in the pulmonary edema leading to rupture. There can be secondary hypertension which can lead to erosion of the pulmonary vasculature giving rise to hemoptysis.
Hmm.
Infective endocarditis in rare cases.
Hmm. You mean mycotic aneurysm involving lungs?
Yes, sir.
Arterial, huh?
Yes, sir.
Okay. And infarction. Okay,
Yeah,
infection.
infarction.
Okay, right.
Yes.
In mitral stenosis, will you get what are the mechanisms of hemoptysis?
In mitral stenosis, there is an increase in the back pressure to the
Hmm.
lungs because of the
Hmm.
stenotic mitral valve on the left side, which can
Okay, what are
give
the
rise to pulmonary edema, which can give rise to a pink prothesputum
Yeah.
most likely. However,
Yeah.
if
Then,
there is a significant increase in pressure, it can lead to rupture of the pulmonary or the bronchial veins and can give rise to hemoptysis.
good. Then, any other mechanisms? Other mechanism of hemoptysis in
Hello.
mitral stenosis. Other
Hello, sir.
mechanism of hemoptysis related to
Hello,
mitral
sir.
stenosis. Hello, audible?
Hello, sir. Good
Hello,
evening.
hello, hello, audible?
Hello, check number 2. Can you hear me?
Some net problem that I have.
Unmute yourself and speak. Hello? Can you please unmute yourself?
Hello, hello.
Hello, yeah. I can hear
Hello.
you.
Can the organizers please sort this off? The time is getting.
Hello. I can hear you now.
Hello, sir.
Okay, right. Okay,
Hello.
all right.
Yes, sir.
Then you go ahead with your presentation, and now you combine all the three symptoms and say a few pathological possibilities.
Hello, sir.
Hello.
Could you please repeat hello?
Now, after
Hello. Yes,
that
sir.
history of breathlessness, loss of weight,
Yes, sir.
recurrent hemoptysis, you say
Yes,
a
sir.
few pathological possibilities. Okay.
Based on the basis of the given history, along with recent onset right-sided pain, the most likely etiology can be a right-sided collapse of the lung. It can be because of a neoplastic cause. It can be because of a the history is not suggestive over here, but it can be because not because of loss of fever, but it can be because of tuberculosis cavity
Hmm.
on the
Hmm.
tuberculosis also can be a cause for the same.
Okay, right. So you are thinking malignancy or a tuberculosis, isn't it?
Yes, sir. Yes, sir.
Between these
Yes,
two,
sir.
what is your first choice? Malignancy or TB?
Yes, malignancy, sir.
Malignancy. Okay, right.
Yes.
So which side? What are the? How will you? Which are the side determining symptoms and in respiratory system? You can say right side or left side. What are the?
So,
Is it clear?
hello,
Hmm.
sir. We will check in for the first of all. We will check in for the deviation of the superior mediastinum or
No.
the inferior mediastinum.
That is no. From the history, you can find
Yes,
out
sir.
which side is affected, right or left. So, what are the some clue from the
Right,
clue from the history?
right side because there is a history of right-sided chest pain.
Chest pain.
It is
Okay,
given that there is right-sided chest pain, so it is more likely to be of the right side.
okay. So, is it a
Yes, sir.
fixed chest pain or a pleuritic chest pain? What type of pain is this? Okay.
It is not likely to be a pleuritic.
Hmm.
It is not likely to be a pleuritic chest pain because pleuritic chest pain will be very sharp in character.
Okay, so it's a constant dull type of pain. Maybe
And it
something
will
will be
be
infiltrating the chest wall,
yes,
isn't it? Okay, right.
yes,
Go
sir, yes,
ahead.
sir.
Yeah, with your general examination findings.
On examination, there is right supraclavicular lymph node which is palpable. There is drooping of the shoulder on the right side, and on
Hmm.
percussion, there is an impaired note in the right supraclavicular, infraclavicular, in the right mammary area, in the right axillary area, posteriorly in the right interscapular and the suprascapular area. And on
Hmm.
auscultation, there is decreased breath sounds in all these areas.
Okay, my question is, what are the anatomy of?
Yes, sir.
Tell me the anatomic. I mean, oblique fissure and horizontal fissure, surface anatomy. Oblique fissure.
Hello.
Can you hear?
Hello. Hello.
Oblique fissure. Oblique fissure,
Yes, sir.
surface anatomy.
Oblique fissures are what?
Surface
Hello.
anatomy. From where it starts, where it ends. Oblique
Sorry,
fissure.
10 minutes.
From the on the medial side from the fourth. Hello.
No, backside you
Hello.
start. Which spine it starts? Hello?
Fourth level.
Huh?
Hello.
T7. starts at the
extending
spine level and at which coastal control junction it ends.
yeah, around fourth.
Fourth or sixth,
Hello, sir.
where it starts, where it ends. Because without knowing this, no, the respiratory system will be very difficult, no? Because you should know where is upper lobe, where is the middle lobe, where is the lower lobe. To understand this, no, you
Yes,
need
sir.
this anatomy knowledge. Oblique fissure, horizontal fissure. Horizontal fissure starts where and ends where? Because the middle lobe is between the oblique fissure in front and horizontal fissures, isn't it? And above the
Fourth,
horizontal fissure,
fourth,
hmm,
along the fourth rib.
fourth coastal control
Along the
junction.
fourth rib, sir. Yes,
Okay,
sir.
forget about that question. You study that well. Okay. Then only you will be.
Okay, okay.
So here the findings are confined to which lobe? Hello?
Right-sided upper lobe.
Right upper lobe,
Hello,
isn't it?
right-sided upper lobe.
Right upper lobe. Okay.
Yes, sir.
So what do you think? Auscultatory findings.
Hello. Yes, sir.
Proceed with auscultatory
Auscultatory
findings.
findings. There is a
Ah,
decrease in the breath sound, sir.
decrease in the breath
Hello.
sound in the right upper lobe region, isn't it?
Yes, sir.
Infraclavicular, supraclavicular, upper interscapular area, supraclavicular, scapular, and axillary region. There is a reduction in breath sounds, isn't it? Okay.
Yes, sir.
Okay. That is breath sounds. Any
Yes, sir.
added sounds like crepitation, ronque,
No,
or
no,
rub?
no, no adventitious sounds.
Any bronchial breathing heard?
No adventitious sounds.
Okay. No, adventitious
Hello.
is for
No, no
cardiovascular and
adventitious.
added for respiratory. Added for respiratory and
Hello.
adventitious for cardiovascular. Can you hear? Hello?
Hello. Yes, sir.
Okay.
Hello. Yes, sir.
Yeah. So what do you think? Here, diagnosis possibly fibrosis or collapse.
Collapse of the right-sided upper lobe.
Right. Why not fibrosis? Why not fibrosis? Why can't be right upper lobe fibrosis? Hello.
Hello, sir. There is also a palpable lymph node which is palpable, which is more likely suggestive of a malignancy in this case, because of which there can be a collapse.
Yeah. What type of collapse is absorption collapse or compression collapse?
It is more likely to be a compression collapse. It can be both. It can be compression as well as absorption collapse. Absorption, if it goes on to invade in the inner structure and the walls of the conducting system.
Yeah. So growth you are suspecting is inside the right upper lobe bronchus, isn't it? That is producing,
Yes,
or
sir.
a lymph node may be compressing. Okay. Right.
Yes, sir.
What are the general examination findings? Other than one is lymph node. Anything else?
Nothing else has been mentioned over here, but I would suspect there would be clubbing also, which would be present in this particular patient.
In the general exam, is there
Along
any
with that,
clubbing?
yes, sir.
General examination finding only scalene node. Any other finding?
No, sir, they have not mentioned anything over here, but I expect that clubbing can also be present. Also, I would like to check in for the peripheral pulses because the patient is a smoker.
Hmm. Okay, you are suspect. You want to know. Very good. Peripheral vascular disease. Okay, atherosclerosis. Okay. So right. So your diagnosis right upper lobe. What about the
Right-sided
lymph
upper lobe
node?
collapse, most likely due to
Ah,
malignancy.
malignancy. Okay. Okay. Right. Very good. Very good. How will investigate?
For investigation, first of all, I would like to carry out the basic investigations, the
Hmm.
CBC, hemoglobin, ESR.
Hmm.
Along with that, I would like to go for the sake of completion, serum electrolytes, LFT, RFT, along
Hmm.
with urine examination. Moving on to appropriate proper investigations, radiology, I would like to go with X-ray and a CT scan.
Suppose you are suspecting bronchogenic carcinoma. His
Yes, sir.
electrolyte is 130 sodium. That is normal or abnormal? 130 milliequivalents.
130 milliequivalents is slightly low, but still fine.
Low. Okay, low. Potassium is 5.
It's 5 is in the normal, near about normal range.
So what condition will you suspect with this electrolyte abnormality in a person with bronchocarcinoma?
Can it be symptom of inappropriate ADH secretion, which can give rise to hyponatremia?
Yeah, that is hyponatremia, but with the hyperkalemia hyponatremia combination in a person with CA lung indicates what? Hyperkalemia, hyponatremia, and sometimes blood sugar will also be low.
Blood sugar is also low.
Mm.
Bronchogenic carcinoma.
Mm. Okay. One more. You have two more left. Two more.
One more.
One more. One more. Okay. Last. Okay. Right. Call.
Okay, I'll call it test number. Hello, test number 3. Hello, test number 3. Am I audible? Can you please unmute?
Good morning, sir.
Hello,
Yes. Good morning. Audible?
Yes, sir. Am I audible to you?
Oh, yeah. You are audible. Okay. Go ahead with your presentation.
Sir, a 32-year-old female. She gave a history of polyarthritis for past 6 months, and also there is a history of ANA positivity. Now she presented with acute onset of weakness of the left body for 2 days. Also, she complained of double vision on looking on left side. It was horizontal type of diplopia, and it was more on looking near objects rather than at distant objects. There is no history of drooping of eyelids, no other symptoms pertaining to any higher mental functions or cranial nerve involvement, no extrapyramidal involvement. Sir?
Okay, no symptom attributable to dysfunction other cranial except for this double vision.
Yes,
no.
Sir.
Okay, hair function and other cranial not involved. Then
are normal. Extrapyramidal no involvement of extrapyramidal system, no sensory abnormality, no abnormality in bowel and bladder functions.
test number 3. Can you put on your video?
Okay, I'm hearing you. I can hear you. Okay.
So shall I continue?
Continue. Yeah.
Yes, sir. So examination slide, please. Thank you. So on examination, there is impaired
1 second.
addiction.
No? After this history,
Yes,
because
sir.
your analysis of history is very important and how you are approaching a case, that's the most important thing. No? How is your approach? So
Yes,
let us go with your evaluation of this patient's symptom analysis and
Yes,
anatomical localization. That's the most important thing in neurology, isn't it?
Yes, sir.
Okay, so you analyze the history and fix anatomically the lesion.
Yes, sir. Sir, I would like to start with the history. She's a 32-year-old female. So she belongs to childbearing age, and she's a female. She also gives history of polyarthritis. And also the ANA is positive. So with that history, yes, sir. So with that history, I do suspect a vasculitis like SLE, secondary vasculitis like SLE, because of the age, the predisposing age, and the polyarthritis history. Also, the screening test, which has good sensitivity, like 98% it is positive. So next slide, please. Okay, now with the history of symptoms. She said there is acute onset of weakness of left body. So for 2 days. Also there is double vision on looking left, on looking towards left, and more on looking at near objects than distant. So acute onset suggests to a vascular etiology of cerebrovascular accident. Then she also gives an history of double vision. So probably there is
she has weakness. No, weakness indicates due to, is it an upper motor weakness or a lower motor axis
Sir,
weakness?
with this much history, it's just given that acute onset of weakness. So most probably, maybe with the examination, we can more confirm that it is due to a UMN lesion or with other.
Now this presentation with double vision and one side of that is weakness of left half of the body, that is hemiparesis or plagia.
Yes, sir.
So is it an upper UMN or LMN?
Sir,
Lower motor neuron
UMN.
axis.
Sir,
It
upper
must
motor
be
neuron lesion.
upper motor neuron. Upper
Yes,
motor
sir.
neuron axis, you say.
Yes, sir. Yes, sir. Access.
Because if you are saying that if the lesion is in the brainstem,
Yes, sir.
you are mainly suspecting the white matter involvement, that's isn't it? Hmm?
Yes, sir.
So
Yes,
it is
sir.
upper motor neuron axis.
Yes, sir.
Okay. Then, okay. So, right. So then you have to go details of that visual problem.
Diplopia. Yes, sir. When a
Okay.
patient comes with diplopia, first of all, we should rule out whether it is an ophthalmic case or if it is a neurologic. So we should know whether it is an uniocular diplopia or binocular. So I would like
Yeah.
to ask the patient to close one of the eye. So even if after closing either of the eye, if that diplopia is persisting, it means it is an ophthalmic case. While diplopia only present if both the eyes are kept open, that means it is binocular diplopia and a neurological cause, most probably.
Okay.
So here the patient complains of diplopia looking more on left side. That is it is a binocular diplopia and horizontal diplopia. Horizontal diplopia can be due to some of the causes for horizontal diplopia are internuclear ophthalmoplegia, vestibular nucleus lesion, or vestibular nerve lesion. These are some of the causes for horizontal diplopia. Now, the patient also complains of nystagmoid movement. Oh, sorry, that's on examination. Sorry, sir. Uh,
Ah.
should I say that it here?
Okay. So now with this now, what are you suspecting the reason behind this devolution? Which
Sir,
structure
most
can
probably due to internuclear ophthalmoplegia. That is a lesion at the MLF.
Why not third nerve related
Sir,
diplopia?
she gives no history of ptosis
Why
and
not
accommodate.
a lateral access related devolution?
Sir, the diplopia is present only in adduction, not in abduction.
In upper motor neuron lesion, will you get diplopia?
Yes, sir. Yes, sir.
Upper motor neuron corticonuclear fiber involvement, will you get devolution?
Yes, sir. The MLF, when an MLF is involved.
Okay. Right,
Yes,
right,
sir.
right.
Medial longitudinal fasciculus.
Okay, okay. Go ahead with your presentation.
Yes, sir. So there is no other history like drooping of eyelid, no higher mental function features, no other cranial nerve involvement, no extrapyramidal involvement, no sensory abnormalities, no bowel bladder dysfunctions. So now coming to examination, there is impaired adduction of the right eye. And the left eye shows nystagmus on abduction. So this means that there is a lesion
What
for.
about other cranial nerve involvement?
Sir, no other cranial nerve involvement.
Okay. So where is the lesion?
Sir, medial longitudinal fasciculus.
Which
of
side?
Right
Left or
side.
right?
Of right side. Since the patient has adduction difficulty of the right eye.
Is there any involvement of paraponderal reticular formation?
No, sir, because the lateral rectus seems to be normal. Their lateral abduction is normal.
Okay.
10 minutes.
So, pardon? 10 minutes over.
12, yeah. Yes.
Okay. No problem. Right. Right. Okay. Right. Proceed. I mean,
Yes,
go
sir.
ahead.
Now,
Okay.
the left eye shows. Left eye shows nystagmus. That is, the nystagmus is confined to the abducting eye. That
Okay.
means it is a jerky nystagmus, gaze type nystagmus. So again,
Okay.
pointing towards MLF lesion.
So, where is this lesion of MLF happened here? Is it in the pons or in the midbrain?
Sir, I don't know. Since there is no other features of other cranial nerve involvement or other features like red nuclear involvement or myoclonus or tremor, I think most probably it is involvement of midbrain, where MLF is also involved, as well as due to the weakness of left side. There is hypotonia and extensive plantar on left side. So pyramidal tract is also involved. So
why there is hypotonia?
Sir, maybe neuronal shock. It's just 2 days of presentation. So maybe she is in neuronal shock of UML lesion.
Okay, is there any cerebellar signs on left side?
No, sir.
Why?
Sir, left. No, sir. ML. If there is no involvement of superior cerebellar peduncle.
No, is there any cerebellar signs elicited? Left is weak, left side, hemiplegia is
Yes,
there.
sir. Yes,
In that
sir.
side, is there any cerebellar symptom or signs?
Sir, I have been given this case. It doesn't say about cerebellar signs.
No, what is the power?
Sir, power is grade 2. Grade 2.
Then what is my question?
Sir, ataxic hemiparesis question.
No, with grade 2 power, will you be able to comment about this, whether the cerebellum is involved or not?
No, sir.
Yeah.
No, sir. More than 2 is required for that.
Yeah.
Yes, sir.
Right. So your localization is where?
Sir, medial midbrain, most probably due to basilar arteries. Medial midbrain, affection of MLF.
Midbrain or pons?
Sir, there are no other features of cranial nerve involvement or other features like myoclonus or tremors. So,
may not be
or maybe
needed.
superior pontine. Maybe superior pontine. Yes, sir. Maybe superior medial pontine lesions affecting MLF. Yes, sir.
Okay. So she's having polyarthritis with ANA positivity. That indicates what?
Sir, SLE, systemic lupus erythematosus.
Now you correlate SLA with this presentation.
Sir, SLE, the most common nervous system manifestation is cognitive dysfunction. But here it can also cause other features like mood depression, mood disabilities, and as well as stroke and TIA, transient ischemic attack. So in this case, I suspect stroke due to SLA since there is no other history. Since this is a case of young stroke, and we should also rule out the other possibilities related to this since she is young lady, for example, any rheumatic heart disease or any procoagulant conditions like protein S deficiency, protein C deficiency, antithrombin D deficiency.
That's very good, very good, very good. Wait.
Also,
again, if you're suspecting mid-brainstem involvement in this case now,
yes, sir.
You're suspecting an artery, SLE antibody mediated or vasculitis related part.
Yes, sir. Yes, sir.
Vasculitis, no?
Yes, sir.
Which vessel?
Sir, basilar artery. Since it is medial, we are suspecting.
How is the basilar artery formed?
Sir, basal artery is formed by the combination of two vertebral arteries, and then it gives branches like paramedian branches, short circumferentials, which will supply the lateral part of midbrain, and long circumferential or the superior cerebellar artery, which will supply the superior cerebellar peduncle. And in this, since this is a SLE case, it can be due to many mechanisms like embolism, cardiogenic, like in SLE, there is increased risk of Liebman-Sachs endocarditis.
You forget about embolism, atrial fibrillation, all very unlikely.
Vasculitis.
Now vasculitis part, and I want to know which is it a main basilar artery that is blocked here? Is it a stem of basilar artery got occluded here?
No, sir.
Why?
No, sir.
Why?
Sir, since other features, there are no cerebellar features also, there are no other pontine features, since these are also supplied by the basilar artery. If it was a stem occlusion, these features should have been there. Very
good. Right. So which artery is it? A short circumferential? I mean, so which branch is it occluded of basilar artery?
Since I'm suspecting an MLF lesion, therefore there should be a lesion in the medial midbrain or the superior medial pons. So most probably paramedian branches of basilar artery.
Very good. Right.
Yes.
That's it. Okay, so SLE vasculitis involving brain stem is your diagnosis with producing a lacunar stroke syndrome-like presentation, isn't it?
Yes, sir. Yes, sir.
You have also discussed about protein C and heparin cofactor deficiency and antithrombin, all those things, young stroke.
Homocystinuria,
etc.
sickle cell anemia, aortic dissections or AV malformations. These are also causes for young stroke.
Okay. Right. Okay. So which poisoning substance can produce stroke?
Sir, poisoning. Sir, methyl iodide, pesticides like methyl iodide can cause vascular occlusion. Then,
Yeah, it can produce. Yeah.
then
Which,
sir,
uh,
sorry.
right. You're correct. Methyl iodide can produce this.
Yes, sir.
Any bite can produce stroke.
Sir, viper venom. Normally, it inhibits clotting, but due to presence of procoagulant factors like serum protease, they can or phospholipase, they can cause clotting, occurs and vascular occlusion can be resulted.
Okay, stroke, especially viper bite can produce,
Yes,
isn't it?
sir.
Very good. Yeah,
Yes,
right,
sir.
right, right. Okay, right. Okay, how will you evaluate this patient? Evaluation.
Sir, first of all, I would like to start with a non-contrast CT to rule out any hemorrhage. Then, of course, the blood should be given for routine examinations. Like here, especially for ANA, it is positive. So, anti-double-stranded DNA should be tested because it has a special prognostic value for CNS complications in SLE. So, along anti-double-stranded DNA, then ESR, then other blood sugar, and also check. We should check for the protein C and that is procoagulated states. Then US then CT angiography will be a gold standard in this case because vasculitis is being suspected. So CT angiography should be done. Then it will show if there is any vasculitis, aneurysms, or any accelerated atherosclerosis and all.
What about
Then
MRI, diffusion?
yes, sir. MI is the most accurate investigation is MRI, diffusion perfusion scan, and diffusion flare should be done.
Okay, so suppose the diffusion, her
Yes,
imaging in the first 3 hours of the initial presentation showed a very small lesion in the parapontine region of the pons, which diffusion restriction. That indicates which vessel involvement.
So parapontine region.
Parapontine region is a very small, paramedian
branches of basilar artery.
Okay, how will you manage in that situation? SLE and a small diffusion.
SLE also, since this is a case of SLE as well as stroke. So, and since this is not just a mild flare of SLE, so I would give immunosuppression as well as the management of stroke, so as to reverse the brain injury as well as to prevent. So for immunosuppression, pulse therapy can be given like
okay, that is later
stroke.
On.
Okay, for stroke. Yes, acute stroke. First of all, the BP should be maintained. It should not go beyond 185 per 110. Then, if there is any features of cerebral edema, IV mannitol should be given. Then,
in this patient, I have already given you the scenario. There is no very small lesion. Will you give mannitol?
Sir, no, sir, not in this case. Yes, sir. So thrombolysis can be done.
Thrombolysis,
very small.
You are suspecting whatever may, whether vasculitis or you are suspecting a small little bit
thrombus, so thrombolysis will be done using RTPA.
Then you will give steroid, isn't it?
Yes, sir. Steroid immunosuppression, pulse
other drugs
therapy.
used in the treatment of SLE?
Sir, in case of flare, we give pulse therapy. Otherwise, we give oral prednisolone and then followed by steroid replacing agents like hydroxychloroquine, mycophenolate mofetil, azathioprine, etc.
Very good. Very
good. Then also B suppression and C IV rituximab and belimumab can also be given in that case.
Okay, very good. Thank you.
Thank you, sir. Thank you, sir.
Right. That's all, no? Third case. What is that?
Thank you, sir. Thank you, sir.
Hello?
No, sir.
I can leave.
Okay, thank you.
Yes, sir. Sir, that is
thank you all.
Hello, sir.
Okay, over now.
Yes, sir.
Okay, thank you. It was a very interesting session. All performed well.
I would like to use this opportunity to thank Dr. Rajesh, for joining us despite his hectic schedule. Thank you so much, sir.
Okay, bye. Good day.
I hope everybody has a great day ahead. Thank you.